Okay, so I'm just going to start by doing this disclaimer. So Dr. Lorna Fern is my alter ego, and this is as much her work as mine. So I just want to recognize her right at the beginning. So what am I going to tell you in the next half an hour? Well, I want to, for those of you that aren't aware about cancer services in England, I'm just going to do a really quick overview so you can see the context. I'm going to introduce you to BRIGHTLIGHT, give you the rationale for involving young people, and I'm just going to describe the partnership of what we've done over the last 12 years. And hopefully at the end of this, you'll see how involving patients really does make a difference to your research. So this is just a thanks to Sarah Lee for this, for a beautiful diagram depicting the history of TYA cancer care. And I think I just want to draw your attention right to 1990, because I think there's some of you on the calls that might actually recall that UCLH would have had our 30th anniversary last year had we not had the pandemic. So 1990, the first TYA war opened, and there was all this progress over the last kind of now 30 years now. But I think it's really important to know that in 2002, just to show how young people have always been at the heart of TYA cancer care, is that when we had the first patient conference, interestingly noted, find your scent tumour. So why would we involve young people? Well, Involve is the organisation that represents young people or patients' involvement in the NHS. And I think this was a very lovely quote that really depicts why we need to involve patients in our research and how we deliver services, is because basically they know what it's like to live with it. And I think this was really pertinent when we looked at research in TYA cancer care. So Jeremy Whelan was one of the, who as UCLH born and bred, he was kind of one of the founding fathers of TYA cancer care and having this as a distinct speciality. And when he became the inaugural chair of the National Cancer Research Institute's Teenage and Young Adults Study Group, he formed the idea that you needed to have more than 2 representations. And this is where Lorna came, and they developed the core consumer group, which were 5 young people who had the remit of basically being involved in the development and the delivery of research in young people. And right at the very onset, before there was the James Lind Alliance and lots of priority setting objectives, Jeremy and Lorna wanted to establish what the priorities were for young people. Now, you will note that BRIGHTLIGHT is all about the place of care, which is the 3rd item on here, and I can talk quite happily to you about the other 2 priorities, but this 3rd item, the place of care, was one of the priorities for young people, which is where we started with BRIGHTLIGHT, which came in. Now, there's some of you on the call will probably recall this document. It's very old now, 15 years and more. The Improving Outcome Guidance, which was really the set out of how we would have cancer services in England for young people. And it basically said that we needed to have 13 principal treatment centres specifically for teenagers and young adults, and with the remit that those who were aged 15 to 18 had to be treated in a principal treatment centre, but those aged 19 to 24 should have what we call unhindered access to age-appropriate care. Interestingly, for a nice guidance, this had no evidence. So this is where BRIGHTLIGHT came in. But to be able to start BRIGHTLIGHT and really to develop that programme of work, we had to think about some key questions. So first of all, the NICE guidance, it refers to age-appropriate care. I think it's about 28 times, but never once did it define what age-appropriate care was. We didn't know what the most important elements were of a TYA service. We didn't know what outcomes would be improved. And we didn't know how much this would cost, not just the NHS, but cost young people and their families. So the core consumer group had identified the area. We needed them to help design the research. But first of all, these unanswered questions that I've just referred to needed to be answered. So we worked with them as co-researchers to carry out the research. They helped us analyse the results, and we published these together about what it was like for young people to have cancer and where they were treated. So did working with young people, did it change the results? Well, in all the years that I've been interviewing young people and been involved in service delivery, I don't think the importance of the cleaners would have come out in the discussion. So young people did interviews, they interviewed each other, and they gave then what they thought were the newspaper headlines, and this is what an example, and we discussed this. And it just showed that the importance, we always focus on nurses and doctors and as delivering services, but actually the healthcare team is wider than that. And so this was a very important thing for us to note. And just to give an example of when young people were interviewing each other and there wasn't the involvement of a health professional or a researcher, the kind of things that they shared between themselves. So the next quote came after about 10 minutes into an interview. And now I don't think if I'd have interviewed a young person that they would have been that open with me after such a short period of time. So it just shows potentially how much bias we introduce when we have a researcher or a health professional doing this kind of work. But does this have an impact? Well, it was really interesting. So when one of the papers that we submitted from this work, this was the reviewer comment that came back. And we thought, gosh, yes, actually, we were quite negative in that paper. But when we looked back, actually, this is the kind of information young people were sharing with each other, that they were quite open and honest. And, you know, maybe if we'd have done those interviews ourselves, we would have missed some important information. So we worked with the core consumer group. They told us about the people who were looking after them. They told us about where they were looking after them, and they told us what it was like to be treated for cancer. And all this evidence gave us the impetus to be able to get an NIHR program grant. So just a quick what BRIGHTLIGHT is. So BRIGHTLIGHT is what we call a program of work. It had 6 interlinked research projects that looked at the workforce delivering care, the environment that care was delivered in, the outcomes of people who were receiving care. So this was young people, but also their main carer, and the cost of this to young people and to the NHS. So just to show this, this is the YAP, the Young Advisory Panel. So the group of 21 young people have joined us since the study was funded in 2011. Now you'll see photographs from 2013 to 16. You won't see before 2013 because one thing we realised really early on, well, we didn't get consent to use photographs, and people who will recognise some of these will note that some of these young people are no longer with us. So we didn't feel in a position to share slides of people and photographs of people who were no longer with us, as consent hadn't been given. So all the photographs that will accompany this presentation now are with young people's consent. So what's in a name? We started off with the work with the core consumer group. This was called the Essence of Care. When we put the grant in, the grant application was titled as Specialist Services to TYA with Cancer Add Value. And when you put in a grant, an ethics application, you have to have a short and snappy title. So we called it the 2012 TYA Cancer Cohort Study. Now, those of you that have lived through this pandemic will have realised that trials and research often have snappy names. So you probably are all familiar with things like recovery. So we wanted a short and snappy name for this study. One member of the team came up with the name Colossal Youth, as in it's a big study. We went to a group of young people and we tested that out, and they said, wow, that's a brilliant name for an obesity study. So we kind of realized that the research team naming this study was probably a mistake. So who would have thought? There is actually a methodology for naming things. So we worked with a team from Saatchi Healthcare, and they helped us brand BRIGHTLIGHT. This is an example of the mood boards that they drafted. and one of the YAP who's developing the website. So the 2012 cohort study then became BRIGHTLIGHT. So we had a cohort study, and for those of you that aren't familiar, this is what we call an accrual graph. So the yellow bars, they are what we wanted to recruit, and you will see quite disappointingly, the red line is what we were actually recruited. The black lines indicate the multiple interventions that we put into place as a research team. But we also went to our YAP and said, what should we do? So first of all, they said, your information sheet is 9 pages long, change it. So we worked with them and we developed a smaller, more snappy information sheet. For those of you that work in research know that the information sheets are the bane of our lives. We have to bend over backwards to do what the regulations say, and we know that nobody reads them. So we had this nice snappy number, which patients then read. They said, use social media more. We were using Twitter at the time. We aren't allowed to use Facebook because of the regulations by the trust. We do have a closed Facebook page for the YAP, but that took us about 2 years to get approval for. But we could use Instagram. So we set up an Instagram site, had a competition, photograph competition. We weren't comfortable using Snapchat, and I think this just flags if we do things that young people say, the resource to man these then become really difficult. They said, why don't you use video information sheets? So we created some video information sheets, and they also suggested that we use different professional groups to start recruiting young people. So typically we were asking medics and nurses to do the recruitment across the country. So this just to note that this study was open in 109 hospitals across England. But the YAP, they said to us, you know, our nurses and our doctors, they deliver the care that we receive, but the people we speak to are our social workers and our youth support coordinators. So we trained a group of social workers and we trained a group of youth support coordinators. And this becomes again interesting because regulations enforced inappropriately, I think, by a lot of trusts meant that they weren't then able to recruit because recruitment was restricted to certain other professional groups. But we also did a lot of work in a workshop to find out what young people felt about access to research. So first of all, when they realised some of the barriers that were in place, the YAP were really angry. They said, you know, if there's research out there, it should be our choice whether or not to take part, that we should be given all the opportunities. And the role of health professionals and the value of research is kind of intertwined really, because healthcare professionals are the gatekeepers towards research, but they also need to view the value of it. We need to get them to have buy-in, and if they don't have buy-in, they won't tell young people, and that means young people don't have the choice. So obviously, as we didn't recruit into the study, we needed to make sure that we had good retention. So we went back to the YAP and said, right, how do we keep young people engaged for 3 years to get them to stay in the study? So first of all, we noted that the way we were tracing young people, we were going back to hospitals and saying, where do you keep young, you know, are these young people still alive? Can we still contact them? And we found that young people often left the service within 3 years after the diagnosis. When we contacted their GPs didn't know about them. When we used a method embedded within the NHS digital systems, we then found out 65% of the young people that we'd recruited into the study had changed their GP, which I think in itself is really interesting. We revised the website to make it more interesting for young people, and they specifically wanted us to have blogs to tell them what we were doing. We included infographic postcards every time we invited young people to take part with key emerging findings. I sent young people a personalised letter before the last wave of data collection to try and get them to complete at least that wave. And this survey for BRIGHTLIGHT was delivered through telephone interviewers. So we gave the interviewers guidance on how to speak to young people. But the YAP have also been involved in developing new evidence. So they came to us and said, we get told about fertility, but nobody talks to us about sex. So we did some work looking about the importance of sex, body image and relationships to young people. A lot of information has been given now online, but not necessarily in accordance to the way young people use the internet. So we did some work around how they use online information and what support they need. And I think this particular, our trust particularly, we know about the difficulties young people have at the end of treatment. And so they wanted us to do some more work about what was it like for them at the end of treatment, what support do they need and what information do they need. And this just to show some of the wacky things Lorna comes up with. BRIGHTLIGHT is the largest data set of interlinked data for young people in the world. We link up NHS data, clinical data, and also their patient-reported outcome data. So we wanted to be able to do something more with it, more than what we were doing with the analysis. So we went back and said, let's create some hypotheses. And to do this, we played Hypothesis Twister, which I can give you more details about if you're interested. But interestingly, young people came up with priorities that were very much the same as the James Linder Lyons priorities that were launched a couple of years ago. And the YAP have been very much involved in disseminating BRIGHTLIGHT results. So the first ever results were presented by the YAP at Find Your Centred Tumour, which is Teenage Cancer Trust's annual patient conference. And in 2017, we handed over all our research that we had at that time to a professor of theatre and a group of actors up in Manchester and young people with cancer to create There Is a Light. And if anybody's interested, the link is in this publication here. It's an open access publication, and you can see what young people will make of what they come up with when you just let them do as they will, which is possibly one of the most meaningful things I've ever done in my career, to be honest. And interpreting results, because BRIGHTLIGHT, it was asking them the big question: do specialist services add value? And I suspect you're sitting there thinking, what are the results of this study? And why do we not know these results? Well, the results are actually published, and unfortunately came out in the middle of a pandemic, so we haven't been able to share them as widely as we can. But actually they weren't as woohoo momenty as we'd hoped. So we went to young people and said, these are what we found, what do you think? So first of all, when we asked, the primary outcome for BRIGHTLIGHT was quality of life, and this was decided by young people. And what we found is that at 6 months after diagnosis, quality of life is pretty poor for all young people, as one would imagine. And that improves quite considerably over the 3 years after diagnosis. And what we were looking at was young people having all their care in a TYA principal treatment centre, none of their care in the principal treatment centre. So those who had no care in the principal treatment centre had the best quality of life, and that was throughout the 3-year period. And those young people who had all their care in the principal treatment centre, it was less than those who had no care, but it improved more rapidly, to the point that after 3 years after diagnosis, their care was, the quality of life was pretty much the same. What isn't on this diagram, so this was very kindly sketched out for us during a workshop by Ben Connors, what we don't show here is that those who had some of their care in a principal treatment centre and some in another hospital, they had the poorest quality of life throughout the whole time, which was a little difficult for us to kind of understand and comprehend. And we were trying to make sense of it, but when we looked at the next big piece of work that was done, so this was very kindly led for us by Sarah Lee as part of her PhD, who is one of our CNSs now in sarcoma, is that she found that to have a culture of TYA care, we need some key key things. So first of all, we needed a critical mass of young people, so lots of young people going through the service. You needed those young people going through the service to be able to get competence in your healthcare workforce. So if you're only looking after 2 or 3 young people a year, you're not going to be able to get that competence. But what was really important is that you needed good, strong leadership to be able to get buy-in from the wider healthcare team within an organisation. But again, what was really, really important is that you needed time for this to happen. It needed to evolve. So although young people, when we recruited in 2012, the services were just happening in most areas in England, whereas when we did the case study, there had been more time for them to evolve. So there was a little bit of disconnect in between what was happening in the quantitative data analysis, data collection, to those in the qualitative. But anyway, we went back to young people and we said, you know, what did we miss? And they came up with some very, very interesting observations. So first of all, they didn't think 3 years was long enough to follow up young people, that we needed to be looking at 5 and 10 years after diagnosis, that it takes them time to adjust to coping, having a cancer diagnosis. And actually, this also fits with the philosophy of our TYA care, because we're not providing just for now, not for survival. We're putting things into place to help young people. And I think the government term is to become useful citizens in the future. They also said that our scale, we classified young people about the number of stays that they'd had in hospital, number of admissions. But they said, actually, it's not about the number of admissions, it's how long you've been in the hospital. So can you not look at it at the time in hospital, not just the number of admissions? Now, we did look at 2 specific groups. For example, we looked at lymphomas and patients with bone tumours being the biggest group who had some care in the principal treatment centre and some elsewhere. But I think this is something that we would need to look at more, but we just didn't have the number of patients to look at it in more detail. But I think it's a very important observation. The one I didn't show you here was about the costs of care, which is exactly the same. The cost of care was more in the some group compared to the no and the all. And what young people said is that, you know, every time you go to another hospital, they do all the same set of tests as the previous hospital. Why can they not just get the results from the other hospital and just trust those? And this also comes, especially with the diagnostic experience, when you'll note that there's sometimes a long route to diagnosis for young people, because cancer isn't something necessarily a GP would expect in somebody less than 24 years old. So they're going from place to place to place, having all these different diagnoses, going to different places, which costs a lot of money as well to young people and their families. So BRIGHTLIGHT ended. What comes next? Well, you'll all be happy to know we now have BRIGHTLIGHT 2021, and we're going to do it all again. So starting this year, we're going to do another survey with young people, but we're not doing it longitudinally, just a one-off. But we're going to do rapid ethnography alongside this, so we can look at what is happening in reality at the same time as we're asking what's happening to young people from their perspective. So just to kind of summarize our BRIGHTLIGHT involvement, at the top you can see the different things that we've done, different stages of the study, how it's progressed. And at the bottom is the different workshops, the different ways that we've involved young people in each of these areas. And in fact, if you look, you can see, so BRIGHTLIGHT recruited 1,114 young people. We've actually involved as many young people in the development, the delivery, the collaboration, the consultation, and as co-researchers in this study as we have recruiting them. And now we're entering a new way of working. We never thought we would be doing workshops virtually. We always said we wanted to do things face to face because it was a safe space. But last year we did 3 workshops back to back very successfully. It just loses it a little bit when we used to have a really nice lunch. We always used to have it in a venue, and lunch was always a high point. it's not quite the same in a virtual world. So they're contributing to the wider programme. You'll notice a theme in the way that we name studies now, but they're involved in our studies on theory of recurrence, on disseminating research to young people, on recruiting young people to research projects, but also about trying to find more about the more details about recruitment, in the routes to diagnosis. We also have this quirky little study looking at cancer in prisons. Young people aren't involved in that. We do have patients involved in that, but sadly, young people who have cancer in prison tend not to survive very long. So what have we learned over these years? Well, this is definitely plagiarising. Lorna came up with the 7 Ps. Well, we've learned that to involve young people, you have to be passionate about it, but young people also have to be passionate about joining you. What we've involved young people in things outside of BRIGHTLIGHT. So the NIHR had a TYA stakeholder meeting about how we recruit and get more young people recruited into research. Very, very dry subject, but the YAP were there, they were around the table, they're representing young people within that. We were also contacted by the NHS DigiTrials, which is a new organisation that wanted young people's involvement, so they've contributed to that as well. Needs a lot of preparation. Lorna spent an incredible amount of time before this thinking up things like hypothesis twister, because actually we want to make it interesting and meaningful to young people, so the only way we can do that is really give a lot of time beforehand. We need practice. The first workshop we did, and it was the first workshop Lorna had led after we did the branding work with Saatchi Healthcare, and it wasn't as woohooey and as vibrant as the workshop with Saatchi. And so Lorna came back kind of deflated. But then when we looked at the feedback, because young people in that particular workshop, they were all working in isolation, actually they gave really good feedback. But we've had a lot of practice over the years to make this enjoyable for everybody. It takes money. You need money for user involvement, involving young people. We need to pay their travel. Because it's a national group, we don't debar anybody from where they live. So if we bring somebody up from the southwest of England, we usually need to include a hotel because of the nightmare in travel. We need to feed young people, and this costs money as well. We need perseverance. I mean, it takes time, and it also takes patience to get this right and get young people involved. But most of all, we need post-it notes, and lots of them. We do everything with post-it notes. And when it comes down to it, when we look at feedback from young people, from everything that we put in, it's always the things that are a bit unexpected that comes out in the top 4 things that they find enjoyable. But does it make a difference? Well, this is from one of our young people, and feedback in one of the workshops we did a few years ago. We actually listen to young people, and the fact that we do is something that they acknowledge, and they respect that. So I think it does make a difference. So I can't go anywhere without acknowledging the BRIGHTLIGHT team. We worked together very closely for a long time. Some people here past, some here still with us. And many of this team now continue with the BRIGHTLIGHT 2021. I haven't got a photograph of everybody yet. Hopefully we will have a meeting someday where you can meet in future. So, but just so you can see that BRIGHTLIGHT 2021 does involve the whole of England, and what I haven't included here is that we will be opening this study in Scotland and Wales as well, so we can really get a UK perspective. So thank you very much, and any questions, I will stop sharing.
So Rachel, thank you so much for that amazing presentation, and I think and you know, I've learned so much about your work, and absolutely phenomenal. So we don't seem to have any questions in the chat at the moment, but if people feel they do have a question, then please do come off your audio, and very happy to take it.
Silence.
Or just pop your hand up. I mean, I suppose whilst people are thinking, there's a lot of information to digest. I think one of the things that I was struck by, Rachel, was, we'll come to you in a minute, Vic, was the commissioning, actually. So the issue around young people saying, or the research indicating that actually quality of care was worse when you had people treated in both situations. I guess, what's the conversation with commissioners around that? Because there's often a real drive, isn't there, for this, you know, localness to be seen as the combination of localness to be seen as a good thing.
So this is essentially where BRIGHTLIGHT 2021 comes in, because the service specification that hasn't actually yet been implemented, but that was proposed, really does push for what they're calling joint care. And so our concern is if this same pattern was happening now, that, you know, it's not necessarily a good thing. But what, you know, one of the things that we're confident about is that the changes in services over the last 10 years, I mean, when we recruited the cohort, the NICE guidance had only just come in, and people were really pushing to implement the guidance and the recommendations from that. So the focus really was on how they can deliver those services, how they can build those networks between the principal treatment centre and the MDTs and the hospitals that they link with, that they have the joint care with. And like, these things don't happen overnight. I think we forget at UCLH, we've been in place for 30 years. So we've had 30 years to get to know the hospitals in and around Essex and that we link to. But if it's only just started, then it's actually, it really does take the time to do that, especially as some of the viewpoints and within our adult oncology and haematology colleagues didn't always get why TYA was important. We needed to really do a lot of groundwork to understand that. But what I think Sarah's work really showed is that, you know, evolution over time, that actually you can then start building that culture. So we think now that we will have a different viewpoint. But what Cecilia Bindrola, who's going to be leading the ethnography study around each site in England, what we're going to be able to see is, you know, really look at those links between the connections between the principal treatment centres and where they provide joint care. So we should be able to provide some really good guidance that if things aren't working quite as well as we hoped, we'll be able to provide the guidance to people, for teams to be able to do something about it.
Thanks, Rachel. I mean, there's a lot of content in there, and whilst you've been talking, we've got a couple of questions coming through. So, and I know that Vicky Riley had her hand up for a question as well. So, Vicky, do come back online if you want to ask your question. Do you want to ask a question first, as you were first in the queue, Vicky?
Okay, all right. I mean, Rachel, I could talk about this for years, as I was there 29 years ago when it opened. Yeah. I guess the things I think are really interesting, I guess are really, you know, it's amazing what you've all done, but there's that tension, isn't there, between how an adolescent assesses what's important, and for someone who believes in adolescent care, trying to convey this without it sounding a bit daft, but I hope I'll try to. What I think about my own son, who 3 years ago when he was 18, his perspective on what was really essential is very different to what it is now at 21. Mm-hmm. And those things that for us as nurses are important, like access to clinical trials, etc., is how do we balance between the immediacy of what an adolescent thinks is important versus those other things. And I think of that very famous case where the young person needed the heart transplant, but had been through so much, didn't want the heart transplant, the family, you know, found it very difficult to not go along with it. So, you know, with all the assessments and, you know, Gillick competence and all that sort of stuff, she had a transplant. And she now talks very eloquently in her middle 20s about, thank goodness somebody did do that. Mm-hmm. Because in the immediate moment, she couldn't think of having any more treatment. And I guess that's one of the things I always thought was a tension when you're looking after adolescents, is that they are adolescents. So it's whilst being respectful to them, but also recognizing that they are adolescents. So where they are focused there and now is different to where they might be. And the other thing, Rachel, I think is really amazing, and whether this is something you're probably already doing, I've always thought when we're trying to do the case about principal treatment centres, has there been any work begun on that young person and who they were going to be before a diagnosis, you know, where they may have been sat educationally, aspirationally, whether that was to go to uni or be an electrician, you know, how much does the influence of their cancer and where they were treated influence the socioeconomic progression of them as we move forward? And I just wonder whether there's been any exploration around that.
So this is where we come to the fact that BRIGHTLIGHT has an absolute wealth of data that we have that data, but because it wasn't there as the primary thing that we were looking at for this. So I think Annika Petrella, who's I think on the call, she is employed now to start looking at these data, because the other thing is, I think you're very right in saying about the tensions about what a young person wants now and what they want later. So Annika's doing a lot of work looking about what is age appropriate care and what aspects of those age appropriate care actually make a difference. So Sarah Lee, as part of her PhD, she drafted a model of what age appropriate care looks like, and that's you can get the reference through the BRIGHTLIGHT website, it's freely available. But so what Annika's doing now, she's scrutinizing that model so we can look at the BRIGHTLIGHT data to see what aspects of that actually are important to young people. So this is an evolving, a massive work that we're focusing on.
No, it's fascinating. It's fascinating. So thank you for your time.
Annika, you've unvideoed or you've unmuted about to unmute yourself. Did you want to make a sort of comment in response to what Rachel just said?
Yeah, it was just, I mean, I joined UCLH right before the pandemic, about 4 or 5 days before we were ordered to work from home. So I thought I would just turn my video on as Rachel was referencing, since I don't know many of you by face. No, I think Vicky's point is really, really strong, and it was one that I was also very interested in when I came on board. And we have done some analysis with the BRIGHTLIGHT data and not found a difference on some of those factors around education and work. But as Rachel said, we're testing out the model, which is quite exciting to sort of look at it from a more broader perspective. So stay tuned.
No, thank you. And thank you for your response to Vicky, Rachel. So we've got some questions in the chat now, which is brilliant. And the question from Sarah: were families involved in the studies, or did it solely focus on the teenagers?
So this was interesting, actually. We didn't have funding specifically to involve families, but we worked with a company called Ipsos Mori, and the first interview was done as a face-to-face survey administration. And one of their tricks of their trade is to have a questionnaire, a paper questionnaire that you can give to people who are with the person that's responding to the survey, so they don't interfere. So we were able to do what we called at that time a care questionnaire, which was about unmet needs. This showed some really interesting information, but we did note, so we asked young people to give that to their person that they felt was their main carer. So the predominant respondents for that are mothers. What we're doing with, what we're exploring to do with BRIGHTLIGHT 2021, and this is based back from feedback from a parent up in Clatterbridge, it's up in Liverpool network, was can we involve more people? And we think we can do what we're going to try something what we're calling a social support network, so we can try and get parents, friends, whoever the young people sees as important people to supporting them through their cancer journey, not necessarily their main carer. So watch this space, because it might work, it might not, but let's give it a go. It's an opportunity I think we can't miss.
That's good, and actually it's a really good question, isn't it, around how we look at the wider networks and reflective of how we are as human beings, I guess, in society. There's another question here, Rachel, from Catherine Pengelly. Have any changes, a really helpful question, have any changes been introduced at UCLH following Bright Light? Examples such as how to draw up a patient information sheet.
I want to say, has there been any changes? Probably not specific, but this is an interesting thing when you have a longitudinal study that's taken. We were supposed to have finished this study in 2016. We finished it 2019. The study officially ended the 31st of December. So any ability to come in and disseminate to try and make change has been difficult. And it also, I think, what we've also highlighted is the disconnect with how policy works in relation to research, because many of you will recall that Rachel Hoff, who's one of the professors at UCLH, she actually leads the clinical reference group, who sort of organised commissioning for services for TYA. The government commissioning services were not aligned to the Bright Light results being awarded or released. So hopefully now with Bright Light 2021, we're now working with Rachel to be able to try and then have some alignment between what's happening in practice and what's happening in research. And I think if you'll see when the Bright Light 2021 your team, you may not be aware, but all those people are the lead nurses in each of the principal treatment centres, and we're wanting to work with the lead nurses in clinical practice so we can try and align to practice and make changes.
It feels like pushing a boulder up a hill sometimes, but it sounds like you've got all the right people, part of the evidence building, which is the main thing. And we've got a couple of comments in response to sort of Vicky's very thought-provoking question around, the kind of socioeconomic aspiration and developmental question. So, and I don't know whether Keris or Anne, you wanted to elaborate on your comments at all.
No, I just think it's such a tension in practice, and I wondered how, that whole issue, particularly when looking at sort of complex areas of care, like maybe stopping treatment, changing treatment, transitions of care, how those things are surfaced in the research process. I mean, it's it's complicated, isn't it?
Well, I think one of the interesting things for us that we got with Bright Light, it was a very inclusive study. There was very few exclusion criteria because we could accommodate pretty much any language, we could accommodate any disability that had influence on communication. But one of the things was if people were not expected to live by 6 months after diagnosis. And we did some additional work from Bright Light with a curiously named study called When Cure Is Not Likely, looking at end-of-life care for TYA. And what really came out of that was the barriers that we inflict on research that may be inappropriate. So one of the things with When Cure Is Not Likely, the Bright Light survey had 2 key questions. So question 1 was, are you receiving supportive care or palliative care? And question 2, are you happy to be contacted about other research? Now, the inclusion criteria for Bright Light for When Cure Is Not Likely was that young people knew that they were in 12 months, likely to die within 12 months. So we had, I think it was around 40 young people who responded yes to the 2 questions in the BRIGHTLIGHT survey, who could have been potentially recruited into that study. But when we went back to the clinical teams, the question that we asked is, do those young people know that they're going to die? And we didn't recruit a single young person through that mechanism because they hadn't been told that the cure was not likely. So we have that as we can see that's a barrier for young people being involved. But what we could see in the BRIGHTLIGHT survey is that we've got responses, and we, you know, a really good example is when we had a quality of life score that was virtually 0, and then we look back to see if there was an error. Where is there an error in the data? And then we looked at that young person, completed that survey and died a week later, because when all we asked our healthcare teams were, is this young person alive? We didn't then say, is it okay to ask these young people? Because once young people had consented to come into the study, it was then their choice of whether they're able to do it. And I think this is when we go back to the YAP, when I talked about recruitment into research. And I think the key thing we need to remember with this population from a developmental point of view is they need choice. It's their choice. And I think actually that's all patients that coming into the NHS. We should give people their choice of what they do.
But I think that's the point, isn't it, Rachel, that Vicky was making, that you know, it's a very you know, important role of the healthcare professional to support, and it's the nature of the revelation of the choices that is the very skilled TYA care. I mean, Ali's on the call. I mean, she's been dealing with this. Ali, I don't know whether you can speak to this. It'd be great to hear from you.
And just also to flag, so the piece of work that I haven't presented on this was looking at healthcare professional competence for working with TYA, and I think Vicky and Ali will both say is that this is one of the skills that our workforce needs, because you have to have the balance of being a children's nurse and having that inclusivity and being able to communicate with the young person, their family and their social networks, but also respecting a young person and where they are in that trajectory, but also identifying where they are, because not all 16-year-olds are at the same developmental level. Not all 24-year-olds are the same. And I think, this is again, I think one of the things that Sarah's work also shows is that this is a skill that you don't just learn overnight. You need that exposure to young people to be able to develop that.
Thank you, Anne. We're coming to the end, but I did just want to invite Ali, as Anne invited her, to make a comment. Don't worry if you can't or you've got to go. But do feel free to jump in.
Sorry.
Hi.
I'm just going to move somewhere in quite a sort of exposed space.
Sorry, I know it's apologies for picking on you.
No, that's absolutely fine. I have
Anne.
to be perfectly honest, I was following everything until Anne was just chatting at the last moment, because somebody came up to the desk on the 6th floor to ask me a question. So Anne, could I trouble you just to recap what you'd like me to respond to? I feel quite embarrassed to ask this. But
No,
don't worry. We've only got 3 minutes as well.
Okay.
So.
3 minutes. We were talking about the complexity of choice for teenagers, particularly if the choice is about a treatment transition and possibly when no more treatment is possible. And and that was the sort of issue first raised by Vicky.
I mean, I thought Vicky's the questions or the tensions that she posed were really poignant. I think in essence we don't really know enough. I think what I'm beginning to uncover is just how critical the role of a companion, often a parent, is within the healthcare context, and perhaps that creates attention to the whole philosophy of age-appropriate care and our positioning of how empowered we like to think young people are, and whether the whole ethos is more inclusive of working alongside a companion. I don't know, it's very early days. I think certainly, again, I'm at early stages of my field work, but what I'm unearthing and discovering is that for many young people, and Rachel will have lots of experience of this, when people are feeling not themselves and they're going through difficult treatment, it's quite hard for them to think about participating in research that isn't clinically orientated, that's perhaps more exploratory about their experience. And so I'm beginning to think about trying to understand some of the reasons for that, really, as well as trying to recruit.
Thank you, Ali. And I'm going to have to stop the conversation. And it's funny how when we come to the end, we start to get into the real kind of, you know, thick of things. I just want to close and to say a massive thank you to Rachel for your really engaging, detailed, and I feel very privileged to have really kind of begun to understand your work. So Rachel sits on the Supporting Cancer Care Research Forum Steering Group together with Guy Masis, who's also on the call, Anne Lansley and Rogini Govinda. And I guess, as well as thanking Rachel, I'd like to thank them for being such sort of pioneers in this and getting this going. I'd like to thank you for joining us. It's been amazing having you on the call. I hope it's felt comfortable to be on. I hope you've learned something. We've recorded it, so please, it'll be on YouTube in due course, so you can forward it on to colleagues. And finally, in the last minute, if you'd like to be added to the circulation list, my email is there. Please just email me. We really want your feedback. It's early days in this, and we want to get it right and meaningful for everyone. So we've got a Survey Monkey, which is on the link here, but we'll also send it to you by your email. We will send out a certificate of attendance. Our next session is on the 23rd of June, and we've got the Eventbrite link, which we'll send around to our networks as well. But if you want me to specifically send it to you, then please do contact me. And it's going to be by Ruth Anderson, who's one of our psychologists, and she's going to talk about her PhD work on relational depth. So we're looking forward to that. And finally, again, thank you to you all for coming. We hope you come again. And it's been great having your attendance. And Rachel, thumbs up to you, really. So thank you. And your cat didn't walk across the screen, so that's brilliant. All right, have a good day, everyone. See you in June.
Bye.
Bye.